Hey guys, it's Felicia with Philly Tea Medicine. We're back again with another video. So today is Tuesday, February the 2nd. I still want to wish you guys a happy new year. I know that I'm late. I'm overdue. I have not provided a video in Let's Not Talk About It. I'm here. Okay, so I know you're saying like, all right, Felicia, it's been forever and a day since you dropped a video. What was the tea and how did it really go down on OBGYN? So OBGYN was a 4-week rotation. I started on November 23rd and it went up until Christmas break. So my last day was December 23rd. I was able to rotate through different aspects of OBGYN. So I was on labor and delivery. I was in the OR. I also rotated through the outpatient clinic as well as a perinatal testing facility. Now, I felt like having such a variety of experiences was really good because it allowed me to really have an idea of what it would be like to be an OBGYN. In regards to my labor and delivery experience, I had the opportunity of seeing about 3 to 4 vaginal deliveries, and I saw quite a few C-sections. I would say that I probably saw more C-sections than I saw vaginal delivery. For labor and delivery, I was on that unit 4 different days overall during my rotation. Labor and delivery can be a hit or miss, and this is what I mean. So labor and delivery can be a lot of waiting. However, when things get popping, they move. So you have to be ready. So what would happen is I would typically be going into work from about 7 a.m. and my day would end about 5 p.m. When you go in, you get a list and you have an idea of which patients are on the floor and which patients are scheduled to have C-sections. Me personally, I feel like once you've seen one C-section, you've seen them all, but that's just my personal opinion. In regards to labor and delivery. So when we would go in the mornings, we would check the board, which was usually by the nursing station. We would check the board, and some of the things we would want to look for is in regards to, sometimes they would have like the patient's history in terms of like how many times she's been pregnant before, effacement, the uterus effacement, as well as how far dilated she is, as well as how far the baby has descended through the pelvic canal, basically. And it's ranked by stations. And by knowing all that information together allows you to figure out, okay, how soon is this patient most likely going to deliver, or how far is she progressing, things like that. When you have patients who have already had a natural birth before, then you can anticipate that they're going to go faster than a woman that has never had a child before, has never had an actual vaginal birth. So with the 3 or 4 vaginal births that I did see, one of them were twins and the second one was a singleton. Now, funny enough, and this is what I mean when I say things can get popping really quickly, we saw a patient, she wasn't really progressing far. We went to go check on other patients. When I say we, me and my attending, and literally as we're coming back, like the nurse calls the doctor and say like, the babies are coming. And one twin was already out by the time we made it to the room. And that was twin A. So I was able to see twin B, but it was like super exciting. I've also missed a vaginal birth by like 30 minutes and things can just happen. And the singleton, it was really cool because the doctor really allowed me to participate in the birth. She put my hands over her hands and helped glide the baby out. So that was super exciting. In regards to the waiting time that I talked about on labor and delivery, so things that I did to kind of like bypass the time, read high yield topics, do my practice questions, as well as reading any online material or assignments that I had due for school. With my outpatient clinic setting, I did that 2 different days and it was a private practice. I worked from 8 to 4 on one day and then I had a late day. So we did 12 to 6 p.m. When I was there, it was super busy. Like every 15 minutes, we were seeing patients, primarily looking at postpartum visits, perinatal visits, and then pregnancy follow-up visits as well. So what was interesting about this opportunity was initially when I was working with the attending, I like to really ask from the beginning, hey, what is your expectation of me? What is it that I'm able to do? And it was funny because she basically, popped my bubble and was like, oh, no, you're not going to be doing any exams by yourself or any kind of like history taking because the office is too busy for that. You are going to learn through osmosis. And I must say that really it just really, I was not expecting to hear that. I was taken aback. I was surprised. But I didn't let it ruffle my feathers too much. So basically, I was concerned with that response, especially having an interest in OBGYN. We continued to see patients, and afterwards I then said to her, hey, I'm concerned by not having such a hands-on experience or being able to be so involved that it may affect me making an informed decision if OBGYN is for me or not. And I mentioned that to encourage you all that when you're on a rotation, besides knowing what the attending's expectation is of you, you need to also, in a professional manner, of course, make it clear what is your expectation and what do you hope to get out of it, because it is our education at the end of the day, right? So you want to make sure that you're getting everything and anything out of that rotation. And when I did that and I advocated for myself, she was very receptive of that. And she wasn't receptive in saying it to me vocally, but when we went on to see patients, and ever since me working with her since that point, she included me more in her exams, or she would tell the patients like, hey, Felicia has done this, like, do you mind if she helps or if she does that? So I noticed that. So I encourage you, if you're shy, if you're not shy, speak up for yourself, because this is a very, very important time of your career in medicine to figure out what is that you want to do. And if your experiences are too limited, it may affect your decision process. Also, that attending also let me know that she usually doesn't write letters of recommendations for students because she feels like she sees so many of them and they change so quickly that she's not able to build a rapport. She doesn't feel confident in writing a letter of recommendation for them and all those things. So I felt like I was building enough rapport. I felt like I was demonstrating, my knowledge base, things like that. And I proposed to her like, hey, like, do you think you would be willing to write me a letter of recommendation at the end of my rotation? Like, if you see that I am, basically in a nutshell, am I worthy enough for your liking to support me? And I made it clear a strong letter of recommendation. And she agreed, right? And she agreed and she said it was her pleasure. And the reason why, again, I say that to you is because don't let somebody's usual no stop you from shooting your shot. Right? So if you feel confident in your skill set, if it's a specialty that you think you might have an interest in, so having a letter would look great, I encourage you to ask and make sure you say a strong letter. And if they say no, they don't feel comfortable, fine. But if you ask, and what's more impressive than having somebody once say no, say yes. That's pretty impressive. Now, in regards to my OR, and let me go back also. When she said to me that, no, you will learn through osmosis, I was very taken aback, but I must say I learned a lot just listening to those conversations, and I felt like I was a fly on the wall. So she was correct. It just threw me off. Now, in regards to my OR experience, I had the opportunity of working with a gynecologist oncologist and a urologist gynecologist. Now, these are both physicians who have trained as OBGYN and then have completed a follow-up fellowship. For urology gynecology, the fellowship is about 2 years. If you do gyn-onc, that is about 3 to 4 years after. 3 to 4 years afterwards. When I worked with the oncologist gynecologist, my experience, because I only worked with her one time, we were pretty much dealing with women who had ovarian cancer. When I did urology gynecologist, we worked primarily with women who were having issues with urinary incontinence. They had already seen him in his private practice, which I also worked with him there. And there were other interventions that were tried prior, medications, lifestyle, different things, pelvic floor therapy. And then the surgical intervention was the last resort. And what we did for that is that we implanted kind of like a chip in the kind of like the upper gluteal area, and that's kind of close to your S1, S2 nerve root, and that is the nerve roots associated with the urinary system and like all that jazz right now. And so they did that, and you charge it. It's a pretty cool procedure. And that was very helpful. We had women come back, follow-ups, and really speak on how, improved it was for them in regards to their incontinence, not really having so many of those issues. Tips for the OR: make sure that you read prior to going to your cases, know what's going on, know the anatomy. I had a missed opportunity. I had read up on a case. The doctor didn't ask me anything about what I knew about the case. So what I will say to you as a tip, if you have read, you know what's going on, ask at some point during the procedure a question or something that shows that, hey, I did my reading, I know what's going on. Or, when you're looking at the screen, if they're doing a laparoscopic or a robotic procedure and you know the anatomy, or maybe you have a question about the anatomy, ask. because again, all these things coupled together shows that you are prepared. I didn't do that because I was a little timid in that moment, because I know the OR can be a place of, I would say, a lot of order, and I didn't want to be a distraction, but I realized how I could have turned that situation around. So I'm sharing that tip with you. And in my last experience, I was in the perinatal testing facility, and basically that is a maternal fetal medicine doctor, and their training is also about 3 to 4 years, if I'm not mistaken. And these physicians specifically are really reserved for high pregnancies usually. In this facility, there were sonographers. I was able to go in with them and see them scan a patient. Now, these scans are sometimes regular routine scans that are done outside of the OBGYN's office. That's part of the routine checkups. And some of them are for if the OBGYN in the office has noticed that there's some either abnormality in their growth of the fetus, if too big, too small, question about the anatomy scan, things like that, then they go to this facility and have them done. And if there's any abnormality, then the MFM doctor is able to follow up and share exactly what's going on with those complications. I had the opportunity of sitting in on a few of those conversations, and some of them can be very, sad to deliver, and sometimes it's very difficult to deliver that message. So it was helpful for me as somebody in training to see how to deliver that type of delicate information. And it was the guy that I worked with, he was super, super cool, and he was very empathetic to the female patients that he had. So that was pretty cool. Now, this video is getting super long, so I want to end it here by just basically also providing you with challenges and jewels that I learned on OBGYN for me. So I have to say that OBGYN has had to be one of the most challenging rotation for me. It was the most challenging for me in regards to feeling like I worked so hard to make it evident that I wanted to be part of the team. I had to be intentional that I wanted to be part of the team. And I think eventually, based on my evaluation and all that jazz at the end of the road, it was received well, but I never felt like I had to work this hard on any rotation just to feel present and feel seen on the team. So I'll say that too. Be intentional. If you're in these situations where you feel like you're not being incorporated in the team, just be proactive. That's all you can do. And if you know you left your best foot forward, that's all that matters. Also, I think by not having residents on my service affected also my experience. I have friends who had residents on their OBGYN rotations, and their learning just seemed to be a little bit more intimate. They had residents, really take them under their wings. I didn't really have that type of experience. So and then also not being able to see what it would look like on a resident level to be like an OBGYN resident, I think also impacts my decision or my thought process. Also, working with different attendings, as many different attendings as I did so frequently, that can be a challenge. Because you want to be able to build a rapport, because you want to be able to, your attendings want to be able to trust you to then partake in a delivery of a baby, because that in itself, just with OBGYNs and their patients that they have known for years, is a challenge. It's a high risk sometimes. A lot of things can happen. A lot of things can go well, perfectly. But when things start going wrong, they go wrong quickly. So you want to be able to build rapport with your attendings. You want to let them know that, like, hey, I'm capable. I won't be in your way. You can trust me. So that's very, very key, as well as building that rapport with your patients on the floor as well. So you go in, you introduce yourself, and you ask permission. Hey, do I have permission to participate in your child's birth? And oftentimes they'll say yes, they won't have a problem, but you want to have that respect. You want to show them that it's an honor on your behalf to participate, because you don't have to be in that moment at all. And using your voice, I keep saying that's my theme for this video. Use your voice in a professional way, because closed mouth don't get fed, period. Jules is speaking up. It's a challenge and it's a jewel. And then this is a key thing. If you're in a situation, right, where I was in the clinic and I was being told initially that I was going to have limited hands-on experience. Even if after you speak up for yourself, the fact of the matter still is you're going to have limited hands-on experience. What I will say in regards to combating or being able to decide if a field is for you, Be more reflective, right? Use that time to start realizing, like, okay, do I like the population of people that are coming in? The demographic of people. Do I like it? Do I enjoy it? That's number one. Number two, do you like the type of conversations that you're having all the time? Because in any field, right, you're going to have a lot of the stuff that's like you really don't need to be here, and reassuring them. But are you okay with having those reassuring conversations? Do you like the content of what you're talking about? Do you like the pathophysiology of what you're studying? Do you think you would enjoy, after a long day of work, reading about this topic? Like, it probably would still suck, but it wouldn't suck as much as watching paint dry, you know? Also, are you enjoying the flow of work, right? Like, do you like the busyness of it? Do you like how you could be on labor and delivery, but then you could be in the clinic? Do you like the jumping around, whatever that may look like on whatever respective rotation you're on? Do you like the clinic time? Do you like the OR time? Do you like the types of procedures that they're doing? What is the work demand? How is the workflow of the doctors? And if you're not able to have those hands-on experiences, have these type of conversations. Last jewel before I'm out of here. Be open. Be completely open on your third-year rotations. People tell you that all the time, but seriously, be open. This is why I say that. Because with third year, what I've noticed is that your shift in your interest happens, you develop interest, and sometimes you get a big question mark. You don't know. Sometimes you have to table it, and that's okay. You still have time to figure it out. So I'm going to end it right here because it's been a long video, but I wanted to let you know what your girl's been doing, how OBGYN treated your girl. It was rough. We made it through, but thank you so much for watching this video. And you know what to do. Tell a friend to tell a friend to tell a friend to do what? Subscribe and watch Heyyyyy Medicine. Duh. Bye.